Good afternoon and welcome to today's webinar, How to Advocate for Your Loved One During Hospitalizations. My name is Allegra Jaffe and I am a caregiver specialist with the Fairfax Area Agency on Aging. We will allocate a few minutes at the end of the presentation for you to submit your questions by typing them into the question box panel. There will be a brief survey as you sign out, so please help us by giving us your feedback. Now it's my pleasure to introduce today's speaker and instructor, Dana Hutson. Dana Hutson is a founder of Cancer Champions, LLC, helping individuals and families gain clarity in the confusion of a cancer diagnosis. She compassionately consults, educates, and facilitates for individuals and their loved ones as they navigate a complicated healthcare system, empowering them to make life-altering decisions with confidence. Prior to founding Cancer Champions, Dana amassed a wealth of oncology expertise over a 25-year career within the biopharma industry. She combines her unique knowledge of healthcare system with her compassion for people experiencing a disruptive diagnosis to provide private medical navigation and educational seminars. Dana is a Care Partner Project community educator, past president of the National Association of Women Business Owners Greater DC, and serves on the board of Saharsa Deepa Foundation for Education and Samaritan Ministry of Greater Washington. Dana received her bachelor's degree in marketing from the University of Alabama. Dana is going to share her expertise with us today. Thank you, Dana, and welcome.
Thank you, Allegra, for having me, and thank you, everybody, for taking the time to sit in to gather this really important information.
Thank you for being here, Dana.
Okay, can we go ahead and get started, Allegra?
Absolutely.
Okay, so again, thank you to the county and to Allegra for inviting me here today. I wanted to just give you guys a little bit of background around me and why I feel like I'm qualified to even provide this information today. So the gentleman up here in the top left corner of this slide is my granddad, and Granddaddy was the medical director for those of us who are from Virginia, from the sort of Fairfax County area, of the Lorton prison back in the 50s when it was a working penitentiary for DC. He was the medical director for several years there. My grandmother was a nurse, and I thought I was going to follow in their footsteps and go into medicine. I loved it until I got to my pre-med college courses and met with organic chemistry, which weeded me right out of the program as it's designed to do. And I did a pivot and went to business school and ended up, but I wanted to stay in the healthcare system. So I had a long career in biopharma. Until my dad, the gentleman on the lower right-hand corner, was diagnosed with a rare bile duct cancer, and it became very clear to me in my perception. I saw the delivery of healthcare and what it was like to be on the other end of it, and realized there was a gap and a need for people to come in and help people navigate through complex medical situations. So I left my corporate job and I became a board certified private patient advocate, and that's where I am today. But today I'm actually coming to you guys as a Care Partner Project community educator. The Care Partner Project was founded as a result of Karen Curtis, the woman who started the organization. Her father just had a tragic event with the healthcare system that actually could have been prevented. And the death of her dad has spurred her on to start this Care Partner Project, and it's her life's work. And so today I come to you, the presentation today is being brought to you by the Care Partner Project. So what is our plan for today? So what we're going to do in the short time that we have is give you just a brief overview of the medical landscape, how we got to where we are in the system today, and then we can point out the problem. That's easy. What I also want to do for y'all today is to really give you some practical tips and some great resources to be able to manage and to navigate and to advocate for a loved one during a hospital visit. And then we're going to have some time for Q&A. So I think all of us, most everybody has heard, don't go into the system by yourself. Make sure you take somebody with you, no matter what, whether you're going to a doctor's visit or you're in the hospital or you're told, take somebody with you. And most of us agree that's a smart thing to do. But the disconnect is that we usually bring people with us that are they have no more insight, or they're not any smarter about the system than we are. So we've got the moral support, but we don't necessarily have somebody that's prepared and ready to help us actually navigate the system. And that's normal because you don't learn these things in everyday life. So what we're hoping today, and what I'm confident today, is that once we're through this, you are going to be that someone that might be able to go with somebody to the hospital. The difference will be you will be prepared, you will be confident, you'll be informed, and you'll know what to do. So you truly can be that person that will mean the world to somebody that you're actually advocating for. So let's start with a statistic. So in the United States, there are about 36 million people that will go into the hospital for something, either elective, non-elective situation. Out of those 36 million, they stay on average 3.5 days. If you think the statistic right now is that 1 in 3 of those 36 million are going to needlessly suffer or die from a preventable medical complication. And what they're called are never events. And they're called never events because they should never happen. The most common never events are listed here. It's MRSA, you may have heard of. It's methicillin-resistant Staph aureus, or C. diff. People have heard about C. diff. Blood clots are common. Medication errors are common. UTIs, falls. Oftentimes people will be in the hospital and they'll develop a blood infection, which is called sepsis, bed sores, pneumonias. These are the things that should never happen, but unfortunately commonly do. I want to illustrate this with a gal here. I'd like you to meet Sarah. She is a 68-year-old grandmom, young, active, likes to bowl, obviously, also plays tennis, and she tore her rotator cuff. And so she was going to go in. Her surgeon looked at it, did imaging, said this should be a pretty easy fix, scheduled her to go in for an elective surgery. That should have lasted about an hour and a half, in and out. So Sarah went to the hospital. She just scheduled somebody to drop her off at the outpatient surgery center and was scheduled to come back and pick her up because there was really no need. It was going to be not complicated. Well, what ended up happening is as the surgeon went in to operate on Sarah, he saw that her rotator cuff was actually much more damaged than what it had looked like on film. So she was in the OR and under anesthesia for several hours instead of just the 1 hour that she was originally going to be under anesthesia. Well, what does that mean? Well, that meant when she got out and into the recovery room, she was having a hard time coming out of the anesthesia. It was taking her a little bit longer than it usually should have. And the ER, the recovery folks, not the ER, but the recovery folks were feeling like it might be just to be safe. It might be good to keep her in observation overnight. So they did. So as the evening progressed, she was upstairs in a hospital room and she woke up in the middle of the night and she was disoriented, obviously. She had just come out of anesthesia, probably still groggy from that, swung her legs over the side of the bed, went to go to the bathroom and sort of lost her balance a little bit, was disoriented and dizzy, grabbed for that the side table at the hospital bed. And what do we all know about those tables? They're on wheels. And so it wasn't locked and it went forward. She slipped, fell, hit her head, and was on the floor of the hospital for a while before a nurse realized what was going on and came and helped her back to bed. Well, they had to send her down for a CAT scan of her head because nobody saw what happened and they wanted to make sure she didn't have, any issues. And it turned out that she did have a concussion. And so now they were going to keep her one more day just to be safe. unfortunately, what happened was the next morning when she was supposed to be discharged, she had developed rigors and had it spiked a high fever, and they took her blood and sent it off for a rapid test, only to find that she had an infection somewhere. More than likely it happened, she had some broken skin on the heel of her foot from breaking in some new tennis shoes, and just that time spent on the hospital floor was probably the point of entry for the bacteria. So now she's got this infection. So now that she's put on a broad spectrum antibiotic, and as she's in the hospital now for a couple more days than she should have been, she's developed this pneumonia. Long story short, this poor woman ends up in the ICU for several days on broad spectrum antibiotics, just trying to recover from all these things that happened to her based on an elective surgery to fix her rotator cuff. So this is just an example of how our system is very reactive. It's not very proactive. Why is that? Why does this happen? Well, there's a myriad of things. So this slide, the picture on the left is a much simpler time in medicine. Probably my grandfather could probably relate to this during his training in the 40s and late 40s. You had one physician that took care of one patient, and that doctor knew everything about you. They were also very skilled diagnosticians because they didn't have all the equipment, they didn't have all the tests, they didn't have all the machinery. They were trained and very used to making diagnoses based on sort of just looking at a person. There also was one nurse. One nurse took care of one patient, at the most 2 patients. So it was simpler and more holistic. Fast forward to now, where we are today. And this picture is not very, it's not a hyperbolic picture. There's all kinds of machinery and things that we have now in our hospital rooms. So it's complicated. And so you've got all of the technology that we've got now, monitors and things that we never had before. We have complicated medications. We've got just oodles and oodles of pharmacy, and they're good. It's all good, but it's a lot to manage. Like I mentioned, we have testing, all kinds of testing, even a simple blood test. There are a myriad of panels of blood tests. So you can get this kind of blood test, or this kind of blood test, or this kind of blood test. It depends on what they're looking for. And we don't just have one physician anymore. We have one for every area of our body. You've got your bone doctors and your lung doctors and your kidney doctors and we're very specialized. So it's complicated. And then we add on COVID to this, and what COVID has done to our healthcare providers. They were stressed and frazzled and sleep deprived before COVID, and now even more so. And I just read an article in one of my news feeds showing how the hospitals are going to be bombarded now with a lot of elective procedures and things that people couldn't get done for the last 2 years because of COVID. And now the hospitals are just going to be flooded with people trying to sort of catch up with their health care. So it's going to be even more of an issue. So we have all of that's happening. And then we have just our own selves. So people, not just patients, people, we forget 80% of what we hear, and that's normal. And that's even when you're going to the doctor, say, for a well visit. There's not even anything wrong, really, and you forget 80% of what they say. You add the stress of a medical crisis, and you just don't hear or retain much of what is said. So that's a problem. And then we know that 3 out of 4 of geriatric patients or patients that are 65 or older leave the hospital either with an incorrect prescription or they don't understand the medication regimen that they're supposed to follow up with. And this turns into a problem a lot of times with kickback. Like you end up going back to the hospital because you don't 100% understand, what you're supposed to be doing once you're discharged. And so 20% of the return visits, 20% of people end up going back to the hospital through the ER or something. It's just too much. So that's sort of the picture of where we are, kind of how we got there. And we're not going to solve this problem if we just keep using the same thinking that created the problem in the first place, according to Albert Einstein, which is so very true. So what we're going to work on today is trying to figure out how we can be more proactive, how we can be prepared, how we can sort of change this paradigm so we're not just in a crisis mode every time we are interacting with the healthcare system. So the Care Partner Project, one of the things that is really awesome about this particular organization, at their website, they have checklists for everything. That's one of the ways that you can make yourself smarter and more prepared before you go in and interact with the healthcare system. These checklists vary depending on what you're getting ready to deal with, but they will help you know what to look for, what to say, what you can do, and when to get a nurse. And so we're going to talk about all of these things, and I'm going to give you the practical tips of this presentation moving forward. So let's take Sarah, for example. So Sarah was going to have an elective surgery. So she had time to do some investigating. She had time to look and see what was the best hospital for the procedure that she was looking to have, and who was the best physician that had the best outcomes, that had the most experience for a surgery like hers. So we can try to prevent some of these things that could happen in certain, when hospitals don't pay attention to some of these never events. These three organizations are vetted. These are sites that you can go to and actually look at the hospital rating, look at the doctor's rating. If you have people in your family that are medical, if you've had family members or neighbors that have had similar procedures as you, ask around, try to get people's experiences and figure out what they liked, didn't like. One caution I will have is that World News Report, US News and World Report is one area where not doctors, but the hospitals can be ranked. There's a lot of times you'll be driving down the road and you'll see those huge banners hanging off of the side of the hospital, US News and World Report, best cardiac, best whatever. Those are not, you don't want to go 100% by those. That is used a lot in marketing, and the criteria for that, some of the criteria for that is, how was the hospital food, and how was the parking, and was the building pretty? Like, we don't really care about that when we're actually in there having a procedure. We want to make sure that the physicians are competent, that they're skilled, and that the hospital itself pays attention to these never events, so you're not going to fall victim to one of those never events. This is an example of the hospital safety grade that's put out by Leapfrog. It's one of the URLs that I just showed. And if you go in and you put your zip code, I just used mine, and a radius of mileage, and hit search, it comes up with it comes up with the hospital. Now down here, this is the overall hospital rating. So the Centera down in Woodbridge gets an overall B, but what you can do is click into the individual hospital, and then you can see what is their infection rate, what is their fall rate, what are their never events. You can see how the hospital is rated based on those never events that we're trying to avoid. The other thing that you can do is get a second opinion. So especially if you have an elective surgery, or if you've been given a diagnosis of something that is going to require specialists, most insurances will pay for you to get a second opinion. You want to do that just because you want to make sure that you are getting the most skilled physician, that you're getting somebody that has good outcomes, that you're getting somebody that has done a lot of these cases like yours. You don't want to necessarily go to the first physician that you encounter. And most physicians will honor asking for a second opinion. And if they don't, then that's kind of a red flag, because most of them will be happy for you to go get a second opinion. You want an independent second opinion, which just means, say, for instance, you've got an orthopedic thing, and you go to the Anderson Clinic here in Northern Virginia, and you get one opinion. You don't want to go to necessarily another physician within the Anderson clinic, because most of the time when those guys work and gals, when they work in the same practice, they very rarely will go against one of their colleagues, recommendations. So you want to go outside of, say, in this example, the Anderson clinic, and maybe go over to Inova and see what they have to say. Some of the things you want to ask, and this is just for surgical, there are other things that you would want to ask for different specialties, but for example, as a surgeon, you want to ask them, do they use a checklist? That just means, is there an OR protocol? Do they use a checklist prior to every surgery? Because people that use checklists have better outcomes, it's been shown. You want to know, do you guys introduce yourselves? Like, does everybody in the OR suite know who everybody is? And do they introduce you, the patient, to all these people that are going to be in the OR suite with you? You want to ask them, who's doing the surgery? That sounds crazy, right? Because he's doing the surgery or she's doing the surgery, but that is not always the case, especially in a teaching institution like a Georgetown or a GW or somewhere where they're doing academic, where they're teaching new physicians. It is quite common for, they call them fellows, to be doing part of the surgery. It's usually not the very most important part of the surgery, but they might be suturing up at the end, or so. You want to ask them, are you the one doing the surgery? I don't want anybody else. And even Anderson Clinic has fellows that come in and follow these guys around. You want to ask another, sounds like a crazy question, but are you going to be doing any other surgeries at the same time? And you think to yourself, what? But they do have 2 OR suites sometimes going at the same time, and the surgeon bounces back and forth between rooms. So you might have a PA doing something over here while he bounces over here, and then this PA. So you want to make sure they're not running 2 OR suites at the same time. And then you want to ask them, are you going to be around after this surgery? Are you going on vacation, or are you going to be gone? And why? Because if you've got a post-operative complication, you want to make sure that this physician is going to be around and available and ready to help you. So those are just examples of sort of how you kind of vet what's going on. Now, I'm going to switch gears to being once you're in the hospital. So now we're in the hospital. And usually when I'm in front of somebody live, I can ask people, how have they ever heard of a hospitalist, and do they know who this is? And I get a mixed bag. So back in the day, back in my pharma days, the hospitalist was also called the house doctor. And those were the people that we used to laugh and say they didn't want to work very hard. They were there in the hospital as sort of a safety net and to support the actual physicians that had the privileges. So if your doctor put you in the hospital, your doctor was rounding on you during the day, and then the hospitalist was there in the evening or there when your doctor wasn't there to be able to help as needed. Things have totally flipped now, and now your doctor probably doesn't even have privileges at the hospital. Like they can't even walk in the hospital, and the hospitalist is now the person, they're usually an internal medicine person, and now they are the quarterback, and they are quarterbacking all of your care. So that is your physician when you're in the hospital. Now, why does that matter? Well, you want to get to know this person for your loved one, because they don't know your loved one. They don't see your loved one outside of the hospital. Oftentimes, our medical record systems are not integrated. They're not talking to each other. So even if he pulls files up on the electronic medical record, it may be incomplete. It could be inaccurate. So you are the best resource for the hospitalist to really get to know your loved one and know the conditions of your loved one and who your loved one really is. So you want to get to know this person. And while you're in there with your loved one, you want to take really good notes. We just mentioned that all the ER, the electronic medical records, don't always talk to each other. We could have an electronic medical record in the Inova system that is in Leesburg, and that system's not talking to the system up in Mount Vernon, even though they're all under the same umbrella of Inova. So don't assume that all the medical record systems are talking to each other. So that means oftentimes the caregiver that's in the hospital room with their loved one has probably got the most accurate and up-to-date information around what is going on for that patient at that time. So you want to take accurate notes, and whether you do it with a spiral notebook, whether you want to put it on your tablet, if you want to record it on your phone, however you want to take notes, but the key is you want to take notes. And you also want to know what the plan of care is going to be. And there's usually a big whiteboard at the end of everybody's bed, right? And on that whiteboard, there's tons of information for you to glean. So there should be the goal of what they're working towards. You know, that means once they hit that goal, that's when discharge is going to happen. So you're working towards a goal of discharge. It usually has on there the medications that you're on, when they start, when they stop. There could be test results. There could be tests that are scheduled. You want to make sure that you are also sharing what your loved one's goals are, right? To make sure they're in alignment with the goals of the clinical team. Questions you want to be able to ask, any concerns. This is where the communication, it's like the communication hub is on this board. There's also numbers. You'll have all the nurses' numbers. You'll have everybody's numbers. You want to keep those numbers because they all carry those phones around, and that's how you can get in touch with people that are on the healthcare team for your loved one. And you want to keep an accurate record of who is coming and going in your loved one's room. In that slide, if you'll remember how we have a specialist for everybody, so that you may have orthopedists, pulmonology, and cardiology all seeing you during one hospitalization. Why are they there? What are they doing? What are their contact numbers? You want to get their contact numbers. There's respiratory therapists, there's PT, OT, nutrition. All of these people are coming and going. You want to know who they are and why they're there. And then this is key, because if y'all remember, we just talked about how medication errors or just not understanding your medication regimen after you get out of the hospital is often a cause of rebound into the hospital. So there's ways that you can know what your loved one's medications are on. There's these three organizations that will help you. You can go and look and see exactly what the drugs are, why they, how they work, what the interactions are. And particularly for older adults, the Beers list will give you potentially harmful drugs to the elderly. And these are drugs that could be perfect. They use them for 40-year-olds. They use them for 80-year-olds. Same drug, but a lot of times the way that we metabolize drugs changes as we age. Our kidneys aren't functioning as well, our liver's not functioning as well. So the Beers list will help you sort of see what the potential concerns are for certain drugs in the elderly. And why is it important to keep track of these meds? Well, you as the caregiver, you're sitting there, you can make sure that the right patient is being given the right drug at the right dose, at the right time, and the right route. So like, what does that mean? It just means that they come in and they scan your bracelet and they ask you who you are every time they bring any medication. When Daddy was in the hospital, he got so upset with this. He just got grumpy and said, why do they keep asking me my name? Don't they know who I am? What is wrong with this place? It's important for you and the caregivers and your patient to know they're doing that so they don't make a mistake. It's redundancy, it's on purpose. And if you as the caregiver see that my mom can't take anything by mouth, but they just gave her some pills, then it's up to you to say to the nurse, excuse me, I don't think that's the right route. I think maybe that was supposed to be either oral or an injection. So just by keeping eyes and ears out, because mistakes are made. I mean, even with all the redundancy that we have, mistakes are definitely made. And the same goes with testing. So like I said, our cognitive sort of diagnostics, critical thinking skills are going down because a lot of the physicians are just so reliant on technology and tests and scans and all of that. So you want to keep track of why are you ordering this test? When are you ordering this test? When should I be able to expect the results? Who's going to deliver the results? And what are you looking for? Like, you need to ask these things. And I'll give you two examples. One, if a cardiologist comes in and orders a scan on something, but then the lung guy comes in and he wants a scan on something else, but the scan encompassed the same thing, then you could be billed for two different scans that really they could have used the one scan. Both of them could have used the one scan. But unless somebody's asking, you don't know. So if you hear something like they just got a chest CT, why are we getting another chest CT? Just say, why can't you just use the one we just got? Another example is hospitals use their outpatient blood draws, and they use their imaging centers and everything for outpatients all day long. So people coming in from the outside to get diagnostic testing, they use that all day long. They shut it down at 5 o'clock, and it's 5 o'clock to midnight, and sometimes later is when they're doing all the testing for people that are in the hospital. So it's important to know my loved one's going down for a CT scan, but they're not going down until 11 o'clock at night, because that's when it's going to be open, to let your loved one know this is happening, this is why it's happening. So when they come to get them at 11 o'clock at night and wheel them to the basement, they're not petrified, and they understand what's going on. And then this is a huge one. So I have people all the time that will sit in front of a physician and nod their head and just nod their head. And then we get out of the appointment and they're like, I don't have any idea what they just said. Can you tell me what, I don't understand what they just said. We all have our own vernacular. Physicians and the medical community has its own vernacular. It uses a lot of acronyms and a lot of big words that don't make any sense to the normal, to the rest of us. But to them, they talk like this all the time. So sometimes they slip into this vernacular when they're even talking to us and patients. And that's common. What we need to do is say, I'm sorry. I really don't understand what you're saying. You need to explain that again to me in just simple language that I can understand. And 9 times out of 10, they're like, oh, I'm so sorry. And they'll go back. Do not stop talking to this doctor until you absolutely have an understanding of what it is they're telling you, because you may only have 8 to 10 minutes a day with this person, and they're the ones that are the most knowledgeable about what's going on with your loved one from a medical perspective. So you want to make sure that you glean as much information from them as you possibly can while you have them. So don't just nod your head, be persistent until you understand. And we all go to Google or Bing or wherever we go, and it's great. I mean, the internet's great. It's a great source of information, but it's also got a lot of information that is not so vetted. And so trust what you read, but verify what you're reading. And you can ask your healthcare professionals, like, what websites do they trust? What sites would they suggest that you go to see, so you can become more informed about your condition. But I just caution, don't just haphazardly start looking on the website, because you can go down a rabbit hole that might, one, you'll waste a lot of time because you could be looking at things that aren't even relevant to your situation. This is so practical and it seems crazy, but you would be surprised how many people kind of forget to wash their hands when they come into your loved one's room. And not so much now with COVID, I think people are more hyper aware of it, but as the care partner, you want to make sure that if you see somebody that's forgotten to wash their hands when they come into the room, just ask them to wash their hands. And almost every hospital room now has got the antimicrobial stuff right there at the door. They just pump it and wash their hands. It's not hard. So just ask people to make sure that they're washing their hands, and not just the people coming into your loved one's room, but you want to have on hand your own hand sanitizer. And I would suggest that you get name brand, not necessarily Purell, but name brand, not dollar store or something. Get name brand antimicrobial hand sanitizer, and make sure your hands are clean. Make sure that you clean the hands of your loved one, because what happens is they're touching the bed rail, they're touching the phone, they're touching the remote, they're touching the call button, they're touching the tray table, and then they scratch their face or they play with their IV, like where their IV site is. And that's how they introduce bacteria and get these awful, like, hospital infections. So you want to keep your loved one's hands clean too. And then you want to wipe everything down. C. diff and MRSA live on the surfaces. And so take some Clorox wipes with you into the room and wipe down the tray table and wipe down the bed rails and the phone and all of these things, but take one sheet and wipe one way and throw it away, and then take another sheet and wipe the other way and then throw it away. When we take a sheet and then we just start wiping everything down with one sheet, that's not doing anything. That's actually making things worse. So wipe, but wipe correctly, and that's all in your checklist. It will tell you how to wipe. And you want to make sure that we get dizzy and we get disoriented in the hospital, like Sarah did. And so to prevent falls, wear the slippy socks. They give you the slippy socks. Make sure your loved one puts them on. My father was like, I'm not wearing those socks. I'm like, yes, you are. We're going to wear the socks. You also want to make sure that people don't go to the bathroom by themselves. And oftentimes you as a care partner can help your loved one to the restroom. If they need a cane or a walker, you want to make sure they have that equipment with them in the hospital. If you were in the hospital emergently and you didn't bring yours with you, ask the PT department if you can borrow a cane until you can get yours there. And then this one is huge. The alarms. Hospitals are noisy. And if you guys have been in one recently, those nursing stations look like they are about to launch the space shuttle. There is so much telemetry and beeping and bonking and all kinds of things. All of these alarms, all the noises mean something. And there are lots and lots of healthcare providers that have what we call alarm fatigue. It's almost like they've heard this background noise so much that sometimes they won't hear an alarm. So it's up to you to make sure that if an alarm is going off in your loved one's room and nobody's responding, to stick your head out in the hallway and say, hey, there's an alarm going off in here, and have them come in and address it. I'm going to tell you a story why this is important. Karen, the lady who started this organization, had a friend who was married to a nurse, and he was going in for just a routine hernia repair. The man was in his 50s. The wife asked the recovery room team, who were friends of hers, if she could just run out to the grocery and pick up some things before she came back to get him to take him home while he was in recovery. They said, sure, go ahead. He's in recovery. He became nauseated, like a lot of us do coming out of anesthesia. He vomited. He aspirated the vomit, and the pulse ox, the alarm that tells them that there's no oxygen going to your brain, was going off like crazy, but nobody paid any attention to it. And when she came back, her husband was brain dead. Because nobody paid attention to the alarm, and these were her friends. So it only takes 2 or 3 minutes of not having any oxygen to your brain to have something horrific like that happen. So you want to pay attention to the alarms. You also, if you can help it, not want to be in the hospital during the weekend. So if you are scheduling something elective, schedule it for a Tuesday or a Wednesday. Mondays aren't great either. You want to do maybe a Tuesday or a Wednesday, so then you are discharged by the time the weekend rolls around. Why do we say that? Because hospitals become ghost towns during the weekend. And remember, we talked about the hospitalist, right? Those are the guys that are there, but they could be managing anywhere from 10 to 15 patients, sometimes more, depending on the size of the hospital. And all of the specialists are gone. They're nowhere to be found on the weekends. So if you do have to stay there for the weekend, make sure when you talk to the doctors that come in prior to the weekend, you've got their contact information, you know what you should be looking for and how you can get a hold of them if something comes up. You also want to make sure that, because there's also skeletal staff as far as nursing and things, so you want to make sure that somebody is with your loved one 24/7. And I know that sounds like a lot, but in this day and age, it's just necessary. And so you elicit friends. It doesn't have to just be you. Get some friends, get other family members, but have somebody by your loved one's bedside. If that's impossible, they sometimes, if they have the staff, and it usually won't happen for a weekend, but during the week when they have extra staff, if you can't be there, you can ask for a sitter. And sometimes they'll if they have the personnel, they will put a tech or somebody that'll sit by your loved one's bedside to make sure to listen for the alarms and to make sure they don't get out of bed and do all those things. And this is the thing that most people are the most, they didn't know anything about this. And so I'm going to tell you how you can call a 911 in the hospital. But this is something that you absolutely do not want to do unless you truly are in fear that your loved one's going to die because of whatever's going on and you're not getting the proper attention. It came into being about 2005 is when they started to initiate this program. And essentially, it's when you really feel like things are going badly and you don't know what to do. It's like if you would call a 911 outside of the hospital, then it's that same feeling. Like you're not just going to drive yourself to the ER. This is something we need to call 911 for. You pick up your loved one's phone, you dial 0, you tell the operator, I'm calling a condition help in room 322 for John Doe. And you will have a medical team at the room within minutes. It's essentially like calling a code in the hospital. Now, for some people that seems very drastic and dramatic and they don't think they could do that. And so that's okay. If you still have that feeling or you're not 100% sure, you can always go to the nursing station and say, I'm considering calling a condition help or a condition H for my loved one, and you will get immediate attention because no nurse wants a condition help called on their floor on their shift. So, but again, it's used for really dire emergency. It's not used because my loved one is in pain and nobody's bringing the pain medicine, and so I'm going to do this because, you know, I want immediate attention. It's not for that. It's for when you really feel like your loved one is in a dire situation. I'm just going to address this briefly. Remember, we talked about the hospitalist doesn't know your loved one because they've never seen them really before, probably. So you are the one that knows the cognitive ability of your loved one before they got into the hospital. So if you know that your loved one has no cognitive issues before they get into the hospital, but then maybe they start to have some confusion or they start to have some cognitive changes while they're in the hospital, it often is caused by it's called hospital delirium. And it's just from being in the hospital with, you know, their sleep cycles are confused, they've on medication, they're in a space that isn't familiar, and it can be an onset of some confusion. That could be one. Most of the time, it's related to some kind of an infection, either a urinary tract infection, there may be some medication interaction, some drug interaction that's happening, or they might just be having a bad reaction to narcotics. So before you let people start calling in the psych unit, because that's what they'll do. They'll say, okay, we need a psych consult, we need the neurology to come in, we need all these people to come in. Just say, no. My loved one was of sound mind before they came in here. There's no cognitive issues. Could it be something else? And mention, could it be an infection? Could it be a drug interaction? Just pump the brakes on them calling in all the psych people just because your loved one is experiencing some confusion. You also too want to support your nurses. We just mentioned, even now more so than ever because of COVID. I mean, they're stressed, they don't have enough of them for the most part. They're juggling a lot of patients. So ask them how you can help them. Let them know that you've got these checklists from the Community Care Partner Project. We also do work inside the hospitals to educate the nurses and the staff about the Community Care Partner Project. So sometimes they'll even already know about it. Show them the checklist and say, these are some things. Can I get the blanket? Can I get ice chips? Can I, how can I help you help my loved one? And then keep the room neat. I know that sounds crazy, but I've been in rooms before where people bring so much stuff that the nurses can't even get to the loved one to take a vital sign without walking over just piles of stuff. So try to keep the room neat. And if you go down and get a cup of coffee, or ask them if you can get them one, that will go a really long way. Then we're getting ready to wrap up. So discharge. So take the time you need at discharge. Remember, we talked about the board and the goals. You always want to be asking them, when do you think we're going to be discharged? Not because you're in a hurry, but because they could tell you, like, just one morning, yeah, I think they're going to be discharged this afternoon. And you had no idea, you didn't see that coming, and you're not prepared. So you want to have an idea, when do you think discharge is going to happen? And then you want to start keeping notes about, what am I going to need at discharge? Is my loved one going to need a bedside commode? Am I going to need some in-home aid? Am I going to need some help? Am I going to need, what am I going to need for my loved one when we get home? Because all of that's going to be discussed at discharge. And the discharge planner is the one that's going to help connect you with rehab centers, if that's what you need, or in-home nursing aides, if that's what you need. They're the ones, they will not make a recommendation. So you have to do a little bit of your own homework to figure out which company you want to go with, which nursing facility you'd like to be at. They will just give you a list of who they know. They will not make a recommendation. If you go through all of these things, and this is not the time, by the way, to say, I'm going to go get the car, I'll meet you out front. You want to be there with your with your patient, with your loved one, to be able to hear this conversation and to ask the questions for your loved one. You want to record it if you can. A lot of times people will refer back to the discharge communication once they get home, because remember, we're forgetting 80% of what we hear. You want to also, if you feel like your loved one is just medically not going to do well at home, you just don't feel like they're medically ready, you can tell them, this sounds like an unsafe discharge. I don't think my loved one's ready to go home. I want to appeal this discharge. And that will buy you a little bit more time to be able to let your loved one be assessed by the medical team, maybe have one more, physical therapy treatment before they go home, whatever it is. It's not meant to be used just because you're not prepared. You can't keep somebody in the hospital just because you don't have the bedside commode, but you can ask for them to stay in the hospital if you feel they are not medically ready to go home. So we talked about recording these instructions. And then once they get home, now is not the time to just sort of walk away. People are being discharged earlier and earlier and earlier. And so you want to check in with your loved one at least once a day for the next 30 days after they get home. There could be, I'm giving you an example, there could be an infection that's brewing that didn't manifest itself while they were still in the hospital. So they get home and maybe 2 days later, they spike a fever, they start to show symptoms of a blood clot. If you can address that right away, then you can use antibiotics at home to nip it in the bud. You can take them and get them to the doctor so they can treat the blood clot before it turns into a life-threatening situation and they bounce back into the ER. So you want to stay on top and know what you should be watching for at least 30 days. And you don't have to do all this yourselves. There's so many places to get help, and you can organize the volunteer help through like lots of helping hands, Caring Bridge. These are just a few apps that are out there that will help you sort of manage all the help, manage everybody that's coming in to help. And if you don't have a team or people that you can call on, then that's when it would be a great time to call a professional advocate. We help people coordinate post, hospitalization follow-ups. We help people with medications. We help people find, if you don't know how to find a home aid or you don't know where the good ones are, the professional advocates do, and they'll tell you. So there's lots of ways that you can get help. You don't have to do this by yourself. So that was a lot. I didn't even look at my time, so I hope I've left some time, but this is hopefully showing you how preparation can give you some peace of mind as you enter into this system that is very fragmented and complex. And but if you're prepared and you're ready, then you can be proactive for your loved one and not just constantly in that reactive mode. And if you want to get your checklists and everything, if you go to the carepartnerproject.org, you can find all the checklists plus lots of other tips and practical things to help be a really just a really prepared care partner for your loved one. So with that, I'm going to say thank you. If you heard anything today that you think other people would benefit, or you're part of another group that you think this information would be helpful, then please, I speak to 3 people, I speak to 300 people. So if you think this would be helpful, I'd be happy to bring this information to others. And now I'm going to be quiet for a minute and see if y'all have any questions or any ideas or stories. So Allegra, I'll be quiet with that.
Well, thank you, Dana. And we do have about 10 minutes left to do Q&A, so your timing is great. We have a few questions already here in the panel. I'm going to pull them up for you right now. One of the questions we had, and Dana, if you want to stay on, yep, there you go, you're still up here. So one of the questions I have for you is, they want us to know if they're going to get the slides or the organization information. So we are not sending out the slides because you see they're pretty general, but we are sending out another follow-up email with the information that Dana has shared today with the organizations. Wondering, a really thorough presentation, wondering about professional advocates and how to find one. Also, will you address bringing medical directives to the hospital?
Good questions. And that's just reminding me, I need to put that on that post. So you can find professional advocates a couple different ways. There are directories out there. One is called the Alliance for Professional Advocates. And if you just put in like what you're looking for and where you live, there'll be a whole directory of advocates that pop up. And these folks are licensed. They can do what they say they can do. They've been vetted by the organization. So that's one way to do it. And as far as advanced directives and medical directives, I'm so glad you asked that question. We all should have one. I don't care how old or how young we are. Like, we all should have had the conversations with our loved ones so we know what we want in case we don't have the capacity to answer or to choose for ourselves. So I like for people to have a medical power of attorney. And there is a great organization, if you don't already have your advanced directives, called 5 Wishes. I don't know if you guys have heard of it. It's another nonprofit organization. I'll add this, Allegra, to the things that we're sending out. And it just is a very simple document that helps families have these conversations so people do know what their wishes are. And it's not a threatening, it's very conversational, but it's important. We all could be in a car accident tomorrow. Like, you just don't know when you're going to be rendered not able to make a decision for yourself. And so it's important for everybody to have thought about this and have their directives. Most ERs, when you bring them in, if you, not ERs, but hospitals, when you bring that directive in, ask to have it uploaded into your medical record. Ask your doctors to upload it into their medical record, and then it's there. Then it'll be in your medical record, and you won't have to think, oh gosh, did I bring it? Did I, because it'll be in your record. So ask one of your physicians or the hospital when you get there to upload it.
Terrific. I have a few other questions coming in. Thank you for the excellent presentation. May we share the recording with others when we receive the recording? Absolutely. You can share the recording. It'll also be available on YouTube on the Fairfax County Caregiver website, and it's available to anyone in the public and in the community. And we had another question: will we get a copy of the presentation? In your follow-up email in about 3 days, you will get the recording directly sent to you in your email. Can you please expand on the role of the discharge planner?
Yeah. So sometimes the discharge planner is a nurse, sometimes it's a social worker. Their role is to coordinate everything you may need when you go home. So they are there to discern with you, like, what all the physicians that have touched you while they're in the hospital, all of the post-hospital things that you're going to need. So they will help coordinate not always coordinate, but they'll tell you, you need to follow up with this particular physician at this time. These are the meds that you're on. You need to follow the medical, these meds. They'll tell you about equipment. You know, if you need durable medical equipment, they'll help you find somebody that'll bring a hospital bed or somebody that'll bring a commode, or they'll tell you where to go get it. And then they also have lots of resources around skilled nursing facilities, in-home health aides, and they can help you at least point you in the direction of where those folks are, but they won't tell you, you need to go call this particular organization, right? Because they won't make a recommendation for you, but they'll tell you. And then, but they will help you if you're being transferred from the hospital into like a skilled rehab or something, you need extra, you know, rehab. They're the ones that coordinate with the rehab facilities to get you a bed to go from the hospital into the rehab facility. What a lot of people don't realize is if you've done some homework before and you know there's a certain facility you don't want to go to, like you can have a say when with the discharge planner and just say, I don't want to go over there. Sometimes the beds, sometimes you don't have a choice. Like sometimes there just aren't any beds, but you can work with the discharge planner to sort of navigate where you want to go in the system. I hope that helps. They just try to pull all those loose ends together for you.
Quite a few more coming in, Dana. So here, I'm going to get to another one here. How do we request the hospital not do rounds prior to the visitor hours starting? Or at least how to get the information shared later? We found specialists always seem to come between 6 and 8 a.m. before we have arrived, although it sounds like we should stay overnight to be the best advocate for our loved ones.
Good question. And sometimes you can have to stay overnight. Sometimes, I mean, you can kind of get a gut feel for how things are going, right? If you can't stay overnight. The specialist thing is real because they've got practice hours. So they're in their offices by 9 o'clock. So the best thing to do is to talk to the charge nurse, talk to your nurse and find out when is the best chance of me catching this person. Because it's not the same all the time, but the nurses sort of have an idea of like a rhythm of a particular physician. Like they know, well, he rounds at night, he rounds in the morning, she rounds over here. So ask the charge nurse when's the best time to catch the physician, and then let the charge nurse know and let your loved one know, if I'm not there, I want them to call me. And so you can be in the room on the phone so you can hear what they're saying and you can ask your questions. There is no reason why they shouldn't just be able to call you on the phone and have you in the room during that consult.
Terrific. Does insurance pay for second opinion on a medical condition / treatment?
Sometimes. Most of the time, yes, but I'm not going to say all the time because then somebody will find a time when it doesn't. So you need to just check your policy before you get your second opinion and see what they will and will not pay for. Some of them will only pay for in-network, right? So if you're going to get a second opinion that's out of network, sometimes you have to get a second opinion out of network because the expertise is out of your network. But just know in advance what the policy covers and so you don't get blindsided by out-of-pocket expenses.
This was so excellent. Are there any plans to encourage hospitals to use the same system? Example, Epic.
That's a good question. So they're trying, and the hospitals didn't do this on purpose, but what happened is the government said you have to have everything in electronic medical record by X day. And then we had all these electronic medical record companies selling their system, and everybody bought one so they could be in compliance with the government, but they're not all integrated. And so they're trying now to do the integration, but it's a lot. It's a lot, and they're all different. Some have really great systems, some don't have good systems. So the answer to your question is there's not going to be a seamless solution anytime soon. So the best thing to do is just make sure that you've updated what's in your system and that you're just taking notes and just don't rely on the system because odds are it's inaccurate in some way.
When you're looking for a second opinion doctor, do you tell the doctor's office that you would like to make an appointment to get the second opinion?
Yes. So usually, sometimes you can ask your physician, who would you suggest I go to for a second opinion? I mean, sometimes they will just really give you a specialist in the field. Um, and then you can, when you call the second opinion, you say, look, I need a second opinion. I have this situation. I need a second opinion. So yes, it's good to go ahead, and because they're going to also want a lot of records before you go to the second opinion. That office is going to want to have a lot of scans and tests and a lot of things. You don't want to have to do that again, right? So you tell them, I've already got all this and I'm just coming in for a second opinion.
Okay. And Dana, we are at 1 o'clock. Are you okay to stay an extra 5 minutes to try to get some more questions in?
Sure.
Okay.
Yeah.
And you know, we might not get through all the questions, but we will be providing Dana's contact information. Would you mind, Dana, if folks follow up with you directly if there are more questions?
That's perfectly fine. And also to Allegra, what I've done in the past, if you've got a list of questions there at like the cutoff, just send them to me. I'll answer them as best I can, and you can put them in the email to everybody, to send out.
Terrific. Okay. Can a hospital or healthcare facility not let someone go in and stay in the patient room?
That's a good question. So COVID made this really difficult, right? You couldn't get in and see. The pandemic, things are really opening up now, and so you usually can stay. You usually can stay. The best thing I can tell you is you just want to befriend your nursing staff. You don't want to be a pain in the neck. And once they see that you're really there as a help and that you are a care partner, then they welcome having you there, because you're really going to help them. Like I said, they're dealing with 10 people at all they've got people with critical issues, they've got people with elective surgery issues, and everything in between. So most of them will welcome you staying and helping.
Good afternoon. This was very informative. One thing I do is ask my doctor who is their doctor. For example, when I was diagnosed with cancer, I asked my doctor what doctor she had for surgery. Looks like more.
That's excellent. That's an excellent question.
What do we need to do to get permission to advocate for our loved ones? Sign permissions of some kind.
What you really just need, one, if you've got medical power of attorney, that's really great. And also two, if you have your loved one sign a HIPAA authorization. People hide behind this HIPAA authorization. It's the Health Information Portability Act. And hospital systems and doctors' offices will hide behind that when they just don't want to deal with anybody else. But you absolutely have a right, if your loved one signs that form, that you are one of the ones that can interact and get access. There's no reason why you can't be an advocate. There's no reason. So if they're sort of strong arming you on that, just be confident that you have every right to advocate for your loved one. Get a HIPAA form signed and just forge ahead.
Are there any medical innovations for hospital stays to prevent falls? My mother fell in a hospital as a result of leaning against the food tray.
Yeah, I'm so sorry to hear that. So one of the things that they're doing is the beds now are really smart. They've got the smart beds that know the minute somebody tries to get out of it, if they change, if they shift. So it's a blessing and a curse, because the technology is there to try to help people not fall, to let people know what's going on and every time they move. But it's another one of the alarms. It's a new thing that beeps and bonks and buzzes. But that's one of the new technologies that they've got to try to help people from falling.
Do hospitals have access to patients' medical record, or should we bring the medical list of our loved one?
Okay, so they will have some medical record. They might not have a complete history. They will have at least the medical record of why you're there. They'll at least have the most recent episode of what's happening. I'm glad you brought this up. One thing that you do want to have and you want to carry with you to the hospital is your current medication list. And while you're in the hospital, ask for a pharmacy reconciliation. And that what'll happen is a pharmacist will come and look at all the drugs that are currently in your medical record and reconcile them with what you currently are taking, because you might have been in the hospital last summer for something and they put you on a drug that you needed just for that issue. But now you go to the hospital the following summer and they're still going to have that medication and they'll still bring you that medication because nobody takes the time to look at it and go, they don't need that anymore. They're not taking that anymore. So you want to be aware of what you're currently taking, and ask them to reconcile while you're in the hospital so they can take those things out of your record that you no longer are being treated for.
Okay. And so I know we have more questions, but we are out of time. We will follow up with your questions and get them to Dana, and we'll make sure we get them back to you as well. So we'll take care of that. And again, as you sign out, there will be that brief survey. Please help us and just take a moment to answer those questions so that we can help provide topics that are interested to you. We also wanted to invite you to our next caregiver webinar, Living Better with Parkinson's Disease, Wednesday, April 20th from 12 to 1 p.m. Dana, thank you so much for your valuable information and for giving us your time and staying on longer with everyone. And to everyone in our audience, thank you so much for being here. And I hope everyone has a great afternoon. Thank you.
Thank you.
Take care.